All right, let's talk about a drug that's absolutely wild. It can restart a dangerously slow heart, and it can counteract a chemical weapon. We're talking about atropine, a medication so fundamental that honestly getting a handle on it is a rite of passage for every clinician.
So, picture this. You've got a patient whose heart rate is just tanking. It's dangerously slow. And in the room right next door, there's a victim of nerve agent exposure who is literally fighting for their life. Now, you have two totally different crises, right? But what if I told you there's one powerful answer for both? Well, there is, and that answer is atropine. We're about to find out why.
So here's our game plan. First, we'll cover what atropine actually is. Then, we're going to pop the hood and see how it works its magic. After that, we'll get into the super important stuff, how to use it safely. We'll even look at what happens when you get too much of it. That's the anticholinergic toxidrome. And we'll finish up with a clinical pearl that you're definitely going to want to remember.
Okay, let's dive right in with the basics. What exactly is this stuff, and when do doctors reach for it? So at its very core, atropine is an anticholinergic agent. That name tells you everything you need to know. It works against the body's cholinergic system. Specifically, it targets these things called muscarinic receptors. And that single action is what gives it its power as both an antiarrhythmic drug and a really potent antidote.
And this is where you really start to appreciate just how versatile this drug is. I mean, look at this. At the very top, you've got its most famous job, a cardiac emergency drug for when someone's heart is beating way too slow. But right under that, it's a life-saving antidote for nerve agent poisoning. Then you see its other jobs, like preventing kids' heart rates from dropping during intubation and even drying up airway secretions. It's basically the Swiss Army knife of pharmacology.
So, how in the world does one drug do all of that? Well, the answer is in its mechanism of action, which is actually pretty elegant when you get down to it. Let's dig into the science.
Okay, the magic is all in these two words, competitive antagonist. Just imagine there's a race to a receptor in your body. Atropine is in that race, competing against your body's own neurotransmitter, which is called acetylcholine. But here's the twist. When atropine wins the race and gets to the receptor, it doesn't turn it on. It just sits there. It blocks it. It's like a bouncer at a club door that won't let anyone in.
This is a perfect way to think about it. So, your body has a rest and digest system, the parasympathetic nervous system. It uses acetylcholine as its key to unlock things like slowing your heart down or increasing secretions. Atropine is like a key that fits perfectly into the lock, but it can't turn. It just gets stuck in there, jamming the keyholes so the real key, acetylcholine, can't get in. The rest and digest signal gets blocked, and you get the exact opposite effect. Your heart speeds up, your mouth gets dry, you get the picture. Okay, so we get the theory. Now let's move from the how to the how-to. Because with a drug this powerful, you've got to use it safely. That means knowing the right dose and, maybe even more importantly, knowing when you should absolutely not use it.
So, for an adult with a dangerously slow heart rate, the standard dose is a 1 milligram IV push. And this stuff works fast. I mean, you'll see the peak effect in just 2 to 4 minutes. You can give it again every 3 to 5 minutes, but you stop at a total of 3 milligrams. And there's a really good reason for that cap. At that point, you've basically achieved a full vagal blockade. You've completely blocked the nerve that acts as the brakes on the heart. Now, for children, it's a whole different ballgame. We dose by weight, 0.02 milligrams for every kilogram the child weighs. But, and this is a huge but, here's the critical safety rule you have to remember. You never give less than 0.1 milligrams no matter how tiny the patient is. It sounds kind of weird, but giving a dose that's too small can actually have the opposite effect and slow the heart down even more. That's a classic trap they love to put on board exams.
You have to be so careful here. Because atropine blocks that rest and digest system, it can cause a dangerous increase in eye pressure. So it's an absolute no-go in patients with acute angle closure glaucoma. And you'll want to use it with extreme caution for anyone who already has trouble with urination, because it can make that problem way worse and turn a small issue into a major emergency.
Okay, so what happens if there's too much atropine in the system? Well, the side effects aren't random. They show up as this predictable cluster of symptoms that we call a toxidrome, and it's a direct logical extension of how the drug works. And to remember what this looks like, we use one of the absolute classic mnemonics in medicine. It might sound a little silly, but it perfectly paints a picture of atropine toxicity, the anticholinergic toxidrome. Let's break it down. Let's just map that phrase right onto the body systems. You hear mad as a hatter? Well, that's the central nervous system effect. The delirium and confusion. The dilated pupils, we call that mydriasis, that's where blind as a bat comes from. The skin gets flushed, hot, and you can't sweat. That's your hot as a hair, red as a beet, and dry as a bone. Your heart starts racing, tachycardia. And finally, since that rest and digest system is offline, your gut slows way down and you can't pee. See? It all flows right from the mechanism. And this is where it all just clicks. On the left, you've got the dry anticholinergic toxidrome from too much atropine. On the right, you have the wet cholinergic toxidrome you see in something like organophosphate poisoning, which you can remember with the lovely mnemonic sludge. Atropine directly fights every single one of those wet symptoms. It's the perfect pharmacological opposite. It's really cool when you see it laid out like this. All right, we have covered a ton of ground, but let's finish up with maybe the most important part, the clinical pearl. This is the one high-yield takeaway you need to lock in, not just for your exams, but for real-world practice. So let's set the scene with a real question. Your patient has severe organophosphate poisoning. You know the treatment is atropine, and you know you're going to have to give big, repeated doses. But in this scenario, there's no max dose in the textbook, so how do you know when to stop? And here is the answer. This is the clinical pearl. When you're treating organophosphate poisoning, you don't dose to a number on a page. You dose to a clinical effect. Your target isn't a certain number of milligrams. Your target is the patient's secretions. You keep giving atropine, sometimes way more than you'd think, until you see those secretions dry up. That is your finish line. When you really think about it, atropine is a total masterclass in pharmacology. It shows you the incredible power of just blocking a single receptor, of turning a system off instead of trying to turn it on. And that kind of leaves us with a final thought, right? What other diseases across all of medicine could we treat not by stimulating something, but by strategically and cleverly shutting something down?